Welcome to Module 4, where we'll explore the communications and marketing rules for Medicare Advantage and Part D plans. In this module, you'll learn how to navigate the complex regulations that govern how plans and agents communicate with beneficiaries, ensuring compliance with both CMS and state requirements. We'll start by defining what counts as communications and what materials fall under marketing rules. You'll learn the difference between general communications and marketing activities, including what materials are considered marketing materials and how the Centers for Medicare and Medicaid Services oversees them. Next, we'll cover prohibited activities, like unsolicited contacts or providing inaccurate information, and explain the permitted ways to reach beneficiaries, including proper use of email and other digital tools. You'll also understand the distinction between educational events and marketing or sales events, and what can and cannot be done at each type of event. We'll discuss individual appointments, including the importance of the scope of appointment, as well as rules for social media, confidentiality, and proper use of plan star ratings. You'll also gain insight into prohibited practices, such as soliciting applications before the annual enrollment period, and understand what marketing is allowed during the Medicare Advantage open enrollment period. Finally, we'll review marketing in specific settings, including healthcare facilities and employer groups, as well as rules around referrals, agent compensation, and rapid disenrollment. You'll learn how plans enforce these rules and the potential penalties for violations, helping you stay compliant while effectively helping beneficiaries. By the end of this module, you'll have a clear understanding of the marketing and communications rules, giving you the knowledge to interact with beneficiaries safely, ethically, and in accordance with all CMS guidelines. In this section, we will discuss the applicability of Medicare marketing and communications rules, including who is required to follow them and how these rules operate in different contexts. Understanding these rules is essential for anyone involved in marketing or enrolling beneficiaries in Medicare Advantage or Part D plans. The Medicare marketing and communications rules apply to all Medicare Advantage plans that provide only health benefits, Medicare Advantage prescription drug plans, standalone prescription drug plans, and Section 1876 cost plans. Any individual or organization performing activities related to these plans, whether it is marketing, communications, or enrollment support, must adhere to the rules established by the Centers for Medicare and Medicaid Services, or CMS. A key group affected by these rules are the third-party marketing organizations, commonly referred to as TPMOs. TPMOs include organizations and individuals who are compensated to perform functions such as lead generation, marketing, sales, and enrollment support throughout the chain of enrollment. The series of steps a beneficiary takes from learning about a plan to making an enrollment decision. Independent agents and brokers who are not directly employed by a plan and who may market more than one plan are considered TPMOs. In contrast, agents and brokers employed directly by a plan are not classified as TPMOs. For the purposes of this training, we will collectively refer to TPMOs and plan-employed agents as marketing representatives. Marketing representatives are held to the same standards and requirements as the plan sponsors they represent. This means they must comply with all applicable marketing and communications rules. Plan sponsors are responsible for ensuring that their marketing representatives adhere to these rules, including completing all required annual training and following all CMS guidelines when interacting with beneficiaries. When marketing to employer or union group health plans, most Medicare marketing rules continue to apply, but there are specific exceptions. For example, the prohibition against unsolicited contacts does not apply in this context. Additionally, marketing representatives are allowed to cross-sell other products. Prior documentation for the scope of appointment is not required, and certain restrictions, such as prohibitions on providing meals at marketing events, do not apply. The pre-enrollment checklist requirement and certain marketing representative compensation rules are also waived for employer or union group marketing. While annual testing is not required for representatives in this setting, annual training remains mandatory. Plans offering employer or union group health coverage are generally not required to submit marketing materials specific to these groups to CMS in advance. However, CMS retains the right to request and review these materials if complaints arise or for any reason necessary to ensure that beneficiaries are adequately and accurately informed about their rights and obligations under the plan. By understanding the applicability of these rules, marketing representatives can ensure compliance, protect beneficiaries, and maintain the integrity of the enrollment process. Adhering to CMS requirements is not optional. It is essential for both legal compliance and ethical marketing practices. In this section, we will cover the requirements that agents and brokers must meet in order to market and sell Medicare Advantage and Part D plans. Understanding these requirements is essential for both compliance and effective representation of Medicare plans. To begin, plan sponsors are required to contract with or employ agents and brokers who are properly licensed in the state where they conduct their sales or marketing activities. This ensures that all marketing and enrollment activities are carried out by professionals who meet state regulatory standards. In addition, agents and brokers must be formally appointed by the plan when state law requires such appointments. Beyond licensing and appointment, all agents and brokers working with Medicare Advantage and Part D plans must complete training at least once each year. This training is mandated by law and must include all content specified by the Centers for Medicare and Medicaid Services, CMS. The purpose of this training is to ensure that agents and brokers are fully knowledgeable about the Medicare program, the rules that govern marketing and enrollment, and the specifics of the plans they are selling. Following annual training, agents and brokers are required to pass a written test each year. This test evaluates their understanding of the Medicare program as well as the products they will be marketing. Passing the test demonstrates that the agent or broker has the expertise needed to provide accurate and compliant information to beneficiaries. There is an exception for agents and brokers who market only employer or union group plans. These individuals are not required to complete the annual written test, although plans may choose to require testing at their discretion. Even in these cases, annual training is still required to ensure that representatives remain informed about plan rules and CMS requirements. By meeting these licensing, appointment, training, and testing requirements, agents and brokers help ensure that beneficiaries receive accurate information, make informed decisions, and have a positive experience with Medicare Advantage and Part D enrollment. Compliance with these requirements is a critical part of maintaining the integrity and trustworthiness of the Medicare program. In this section, we'll cover key terms and provide general background information on marketing and communications in the context of Medicare Advantage and Part D plans. Understanding these concepts is essential for ensuring that marketing representatives comply with CMS rules while effectively communicating with beneficiaries. First, let's define communications. Communications encompass all materials and activities that provide information to current or prospective enrollees about Medicare health plans and Part D plans. This can include educational materials, general outreach, or informational presentations. Marketing, however, is a specific subset of communications. While all marketing is communication, not all communication is marketing. The key difference lies in intent and content. Marketing activities and materials are generally subject to stricter regulation and oversight because they are designed to influence plan selection. To determine what constitutes marketing, two elements must be present: marketing intent, and marketing content. Marketing intent refers to the purpose behind an activity or material. If the activity is designed to draw attention to a specific plan or group of plans, or to influence a beneficiary's decision to enroll in, switch, or remain in a plan, it is considered marketing. This includes steering a beneficiary toward plans sold by a particular agent or encouraging retention in a current plan. Marketing content relates to the actual information included in the materials or activity. Marketing content may address any of the following topics: benefits or benefit structure, premiums or cost sharing, plan rankings such as star ratings, and rewards or incentive programs offered by the plan. Even mentioning broad categories of benefits, like dental, vision, hearing, or premium reductions, counts as marketing content, regardless of whether the material goes into detailed specifics. Now let's look at examples of marketing activities. Marketing activities can include providing presentations on plan benefits with the intent to influence plan selection, participating in events where plan brochures or summaries of benefits are distributed, meeting one-on-one with beneficiaries to review the annual notice of change or encourage continued enrollment, or passing out plan-specific information and agent business cards at health fairs. Marketing materials are any materials that contain marketing content. Examples include general audience materials such as direct mailings, newspaper ads, or websites that promote a specific plan and highlight benefits or star ratings. Marketing materials also include agent scripts or outlines for telemarketing or enrollment presentations, brochures promoting enrollment and discussing reward programs for preventive care, presentation slides explaining plan benefits, and social media posts that mention a plan's star rating, low premiums, or other benefits. By understanding the difference between general communications and marketing, and recognizing the elements of intent and content, marketing representatives can ensure they follow CMS rules while providing clear and compliant information to beneficiaries. Now, we will cover how the Centers for Medicare and Medicaid Services, or CMS, regulates marketing activities and communications for Medicare Advantage and Part D plans. Understanding these rules is critical for marketing representatives to ensure compliance while providing accurate and clear information to beneficiaries. CMS regulates marketing activities in several key areas. First, the setting of marketing matters. Different rules apply depending on whether marketing occurs in a healthcare setting, another setting, or during educational versus marketing events. CMS also regulates who may market. Marketing representatives must comply with state licensing requirements, and CMS places strict limits on marketing conducted by healthcare providers. The timing of marketing activities is also regulated, including rules about when representatives may begin marketing next year's plans. Additionally, CMS regulates the methods of contact with beneficiaries and requires certain content standards, including the inclusion of disclaimers and prohibitions against misleading claims. Finally, CMS mandates the review and approval of all marketing materials before use, except for materials developed exclusively for employer or union group members. CMS may still request copies of those materials if issues or complaints arise. It is important to distinguish between marketing materials and communications-only materials. Communications-only materials provide information to beneficiaries without marketing intent. In some cases, materials may contain marketing content, but are not considered marketing because they lack the intent to influence a beneficiary's plan choice. For example, the evidence of coverage is designated by CMS as a communications-only material, even though it contains marketing content, whereas the summary of benefits and annual notice of change are considered marketing materials. Another example is a targeted letter reminding a beneficiary to receive a preventive service like a mammogram or colonoscopy. While it may mention cost sharing and benefits, its intent is to encourage health maintenance, not influence plan selection, and thus, it qualifies as communications only. CMS still regulates communications-only materials to ensure accuracy and protect beneficiaries. While these materials generally do not require CMS review, certain disclaimers must be included, and some communications, such as the evidence of coverage, are required to be reviewed. CMS may also conduct oversight of communications materials when complaints arise or data suggest potential issues. Additionally, CMS regulates how representatives may contact beneficiaries, including restrictions on cold calling, and controls the content of communications to prevent misinformation. All communications and marketing materials must comply with fundamental CMS rules. Marketing representatives and plans may not provide misleading or materially inaccurate information. They may not target enrollees based on income or health status, except in specific cases such as dual eligible or chronic care SNPs. Marketing materials must also be inclusive of all Medicare beneficiaries and cannot suggest that coverage is limited to seniors. Unsolicited contact is strictly prohibited in multiple forms. Representatives cannot conduct door-to-door solicitation, approach beneficiaries in common areas, make telephone calls without a scope of appointment, send texts or social media messages, or leave voicemails after unplanned calls. Exceptions to this rule include conventional mail, email, and other print advertising. Representatives cannot use unsolicited contacts to generate leads, and they may not contact beneficiaries who are voluntarily disenrolling or follow up with attendees of a marketing event without prior express permission. Additionally, leads obtained from other organizations require explicit written consent from the beneficiary before contact. There are, however, permitted contacts under CMS rules. Representatives may initiate electronic contact via email, provided there is an opt-out option. They may return calls from individuals who requested information or contact beneficiaries who have expressly given permission through business reply cards or other documentation. Permitted contacts also include confirming pre-scheduled appointments and contacting beneficiaries who have submitted enrollment applications to conduct plan business. Representatives may also contact current enrollees of the plan or its parent organization to discuss plan business, including individuals in non-Medicare products aging into Medicare, Medicaid plan enrollees discussing Medicare products, and members in Part D plans seeking information about other Medicare products. Contacting Medigap enrollees regarding MA, PDP, or cost plan options is also allowed. Representatives may share general plan information, including annual enrollment period dates, flu shot availability, upcoming plan changes, and educational events. Whenever marketing representatives reach out regarding plan business, the plan sponsor must provide written notice to all contacted beneficiaries at least once per year. This notice informs beneficiaries of their ability to opt out of future calls regarding plan business. By following these rules, representatives can engage with beneficiaries appropriately, maintain compliance, and provide accurate, helpful information about Medicare Advantage and Part D plans. In this section, we will discuss the rules surrounding sales, marketing, and educational events for Medicare Advantage and Part D plans. Understanding the distinction between marketing/sales events and educational events is critical for ensuring compliance with CMS guidelines. Marketing and sales events are designed to influence a beneficiary's decision regarding a specific plan or a limited set of plans, or to encourage current enrollees to remain in their plan. These events may include discussions of plan-specific information such as premiums, benefits, star ratings, rewards, and incentive programs, or the distribution of marketing materials. All advertisements and invitations, regardless of format, used to invite beneficiaries to a marketing or educational event must include a statement providing accommodations for persons with special needs, including a phone and TTY number. Marketing events cannot be held within 12 hours of an educational event at the same location, which includes the entire building or adjacent buildings. At marketing and sales events, CMS requires that plans submit presentations containing marketing content for review before use. During these events, agents may discuss plan-specific benefits and premiums, highlight plan star ratings, explain the merits of a plan, distribute and collect enrollment applications, and provide plan-specific advertisements or general Medicare information. Agents may also provide light refreshments or snacks of nominal value, as long as they are not bundled as a meal. Additionally, agents may collect scope of appointment forms for future personal marketing appointments. However, certain activities are prohibited at marketing and sales events. Agents may not require beneficiaries to provide contact information as a condition of attending an event, including email addresses for RSVPs. Sign-in sheets must always be optional. Health screenings, surveys, or activities that could create the impression of cherry-picking are not allowed. Providing meals or multiple snacks as if they were a meal is prohibited, regardless of cost. Agents may not use information collected for raffles, drawings, or promotional activities for any purpose other than the intended event. Educational events, in contrast, are explicitly designed to inform beneficiaries about Medicare, MA, Part D, or other Medicare-related programs without including marketing content or intent. Educational events may be held in public venues and can be organized by providers, other groups, or health plans. Marketing representatives may engage in communication activities at these events and distribute communications-only materials. Banners displaying the plan sponsor name or logo are allowed, as are promotional items provided they meet the CMS nominal value rules and are free of marketing content. Presentations must remain objective and informative, including health-related topics or wellness information, and may include a healthcare provider as a presenter. Gifts and promotional items at both marketing and educational events are regulated under Section 1128 AA5 of the Social Security Act, which prohibits offering anything of value likely to influence a Medicare or Medicaid beneficiary to receive items or services from a particular provider. There is a nominal value exception. Items worth $15 or less per beneficiary, based on retail price, may be distributed. Cash or cash equivalents, including unrestricted gift cards or debit cards, are prohibited. Gifts must be provided regardless of enrollment status and without discrimination. Multiple gifts on a single occasion cannot exceed $15, and the total annual value of multiple gifts cannot exceed $75 per person. In the case of raffles or drawings, the total fair market value of prizes must not exceed the nominal per-person limit, calculated based on anticipated attendance. Plans must also include a disclaimer in all promotional materials that there is no obligation to enroll in the plan in order to receive a prize, gift, or participate in a communal experience. Gifts or prizes cannot be charitable contributions, and rebates or discounts on premiums or co-payments are not allowed under this rule. Limited value gift cards for specific retailers or items, such as a Starbucks card, are permissible as they are not considered cash equivalents. By understanding and following these rules, marketing representatives can ensure that sales and educational events are compliant with CMS requirements while providing valuable information and a positive experience for beneficiaries. Individual marketing appointments are designed to provide personalized guidance to a single beneficiary or a very small group, such as a husband and wife. These appointments are tailored to the specific needs of the individuals and are not defined by the location in which they occur. The goal is to give beneficiaries detailed, one-on-one assistance in understanding their Medicare Advantage or Part D plan options. Before any individual marketing appointment takes place, marketing representatives must coordinate with the beneficiary to determine which types of products will be discussed. This includes MA plans, prescription drug plans, PDPs, cost plans, or Medicare/Medicaid plans. Representatives must obtain the beneficiary's agreement and document it in a process called a Scope of Appointment, or SOA. The SOA ensures the beneficiary is aware of the topics that will be discussed and prevents unapproved marketing during the appointment. The SOA must generally be obtained at least 48 hours before the appointment. There are 2 exceptions to this rule. First, when the SOA is completed during the last 4 days of the relevant election period, and second, when an unscheduled, in-person meeting is initiated by the beneficiary, such as when they unexpectedly walk into an agent's office or attend a previously scheduled appointment for another individual. If a beneficiary requests information about a different plan type than previously agreed upon, a new SOA is required. Once signed, an SOA is valid for 12 months from the date of the beneficiary's signature. SOAs may be documented in writing, electronically, or via a recorded oral agreement. Acceptable technologies include conference calls, email, fax, prepaid envelopes, or designated recording lines. Importantly, a plan sponsor or agent may not agree to the scope on behalf of the beneficiary. The agreement must come directly from the individual. During the appointment, marketing representatives are allowed to provide plan materials, including enrollment kits and marketing brochures, as well as educational information. Representatives can discuss plan benefits, premiums, cost sharing, and rewards or incentives programs. They may review the beneficiary's individual needs, including healthcare history, commonly used medications, and financial concerns. Enrollment forms may be provided and collected, but only after all required issues have been addressed with the beneficiary. Marketing representatives may not discuss products that were not explicitly agreed upon in the SOA. This includes any Medicare health or drug plans not listed, Medigap plans, dental plans, or other health-related coverage. Non-health care products, such as accident-only policies, life insurance, or annuities, may never be marketed during a Medicare plan appointment. Additionally, representatives cannot introduce additional health-related lines of business during the appointment unless a separate SOA has been obtained that explicitly identifies the additional products to be discussed. By strictly following the scope of appointment rules and limiting discussions to approved products, marketing representatives ensure compliance with CMS guidelines while providing accurate, individualized guidance to beneficiaries. Proper adherence to these rules protects both the beneficiary and the plan sponsor and supports ethical, transparent marketing practices. Social media has become an important tool for connecting with beneficiaries, but its use in marketing Medicare Advantage and Part D plans is strictly regulated. Plan sponsors and their third-party marketing organizations, TPMOs, must ensure that all social media activity complies with CMS marketing and communications rules. Any social media post that meets the definition of marketing, meaning it contains marketing content such as plan benefits, premiums, cost sharing, or star ratings, must be submitted to CMS for review. This requirement applies not only to posts by plan sponsors, but also to posts made by agents or marketing representatives on behalf of the plan. Posts that do not contain marketing content, such as purely educational content without intent to influence enrollment decisions, generally do not require CMS submission. Social media posts are subject to the same rules as other marketing and communications materials. This includes prohibitions on certain types of language or claims. The the requirement to include mandated disclaimers, and the need to accurately represent plan benefits. Failure to follow these rules could result in CMS enforcement actions or penalties. Additionally, republication or reposting of an individual's content, comment, or testimonial that promotes a plan sponsor's product is considered a product endorsement or testimonial. Such endorsements must comply with CMS guidance on testimonials, ensuring that all claims are accurate and not misleading. This helps maintain transparency and protects both the beneficiary and the integrity of the marketing process. By following these social media rules, marketing representatives can use digital platforms to engage beneficiaries while remaining fully compliant with CMS requirements, avoiding prohibited practices and protecting the reputation of both the plan sponsor and the marketing representative. Marketing representatives must follow strict practices to ensure compliance with CMS rules and protect beneficiaries' rights. When interacting with prospective enrollees, representatives are required to provide only CMS-approved marketing materials or materials created by CMS. Any talking points or presentations used during marketing activities must also be CMS-approved. Before enrolling a beneficiary, representatives must fully discuss all CMS-required topics to help beneficiaries make informed decisions. These topics include network information for primary care providers and specialists, prescription drug coverage and costs, premiums, benefits, and specific healthcare needs. For independent agents, brokers, and other third-party marketing organizations, TPMOs, all sales, marketing, and enrollment calls with beneficiaries must be recorded in their entirety, including audio from web-based calls. This ensures accountability and compliance with CMS regulations. Marketing representatives are considered business associates of the plans they represent. As such, they must comply with all federal and state laws regarding the confidentiality of protected health information, PHI, as well as any contractual confidentiality obligations with the plan. PHI includes any information about a beneficiary's healthcare coverage, payment for healthcare, or healthcare condition. Under AHIP, PHI may only be used or disclosed on behalf of the plan. If a marketing representative subcontracts with another individual or entity that may access PHI, a business associate agreement must be in place to maintain the same protections. Plan sponsors must also obtain a HIPAA-compliant authorization before using beneficiary information to market non-health-related items or services. Without such authorization, PHI cannot be used for any marketing purposes unrelated to plan benefits or CMS contract obligations. Personal beneficiary information collected by a TPMO for marketing or enrollment purposes may only be shared with another TPMO when the beneficiary has provided prior written consent. This consent must clearly disclose which entities will receive the information and allow the beneficiary to agree or decline sharing their data with each entity. Independent agents, brokers, and TPMOs must use the required marketing disclaimer when selling plans on behalf of more than one plan sponsor. If a TPMO does not represent all plan sponsors in the service area, the disclaimer must clearly state the number of organizations and plans represented and direct beneficiaries to Medicare.gov or 1-800-MEDI-CARE for a complete list of options. If the TPMO represents all available plans, the disclaimer should note this and provide the same resources for beneficiaries. Disclaimers must be conveyed verbally within the first minute of a sales call, displayed on websites, included in electronic communications, and printed in all marketing materials. Special rules also apply to lead generation activities. TPMOs conducting lead generation, whether directly or indirectly for a plan sponsor, must disclose to the beneficiary that their information will be shared with a licensed agent for future contact. This disclosure must be provided verbally for phone interactions, in writing for mail communications, and electronically for emails or online chats. When transferring a lead to an agent, the TPMO must inform the beneficiary that they are being connected to a licensed agent who can complete enrollment. Plan sponsors, agents, brokers, and agencies must ensure that any lead-generating TPMOs follow these requirements and include them in contractual agreements. By adhering to these required practices, marketing representatives ensure transparency, maintain compliance with CMS regulations, protect beneficiaries' confidential information, and uphold ethical marketing standards. Marketing representatives and beneficiaries must have access to key plan documents that provide critical information about Medicare Advantage, Part D, and other plan options. Plans are required to post certain documents in a downloadable format on their website. These materials include the evidence of coverage, summary of benefits, annual notice of change, provider directory, pharmacy directory, and formulary. The provider directory must be searchable by specific elements such as provider name, location, specialty, and cultural or linguistic capabilities. These documents are essential tools for marketing representatives to determine whether a beneficiary's current providers or pharmacies are in-network, whether the drugs they take are covered under the plan formulary, whether other benefits of importance are included, and the extent to which out-of-network services are covered. Plans are also required to provide these materials to beneficiaries after enrollment. When a beneficiary is provided with an enrollment form or instructions, the plan must also include certain required materials. These include star ratings information, the summary of benefits, the pre-enrollment checklist, and, beginning September 30th, 2025, the Notice of Availability of Language Assistance Services and Auxiliary Aids and Services. The Notice of Availability must also be provided whenever any other CMS-required document is given to a beneficiary, such as the evidence of coverage, annual notice of change, or summary of benefits. For dual-eligible special needs plans, if Medicaid benefits are not included in the summary of benefits, a separate document outlining those benefits must be included with the enrollment materials. Plans must ensure that these materials are accessible to beneficiaries before enrollment is completed. For online enrollments, the plan sponsor must make all required documents available electronically, for example, through website links. For telephonic enrollments, the pre-enrollment checklist must be reviewed verbally with the prospective enrollee, and the beneficiary must be informed where the summary of benefits and star ratings documents can be accessed. By ensuring that these materials are readily available and properly communicated, marketing representatives help beneficiaries make informed decisions, ensure transparency in plan offerings, and maintain compliance with CMS requirements. The Centers for Medicare and Medicaid Services, CMS, releases star ratings to help beneficiaries compare Medicare Advantage, MA plans, and Part D prescription drug plans, PDPs. These ratings are based on a variety of performance measures, including whether members received recommended screening tests, vaccines, and preventive checkups, as well as how members rate the plan on access to care, customer service, and overall satisfaction. Beneficiaries and marketing representatives with Internet access can view plan ratings at Medicare.gov by clicking the Find Health and Drug Plans button. Each plan sponsor is required to prominently post the standard star ratings information document on their website. New plans or Part D sponsors without star ratings are not required to provide this information until the next contract year. Plan sponsors and their marketing representatives must provide beneficiaries with the plan's overall performance ratings using the standard plan ratings information document. Marketing representatives may reference individual measure ratings only in conjunction with the overall performance rating, such as the MAPD overall rating, the Part C summary rating for MA-only plans, or the Part D summary rating for PDPs. References to star ratings must only apply to the service area in which the rating is applicable. Representatives must clearly state that the rating is out of 5 stars and identify the contract year of the rating. The star ratings document must be provided along with enrollment materials. For paper enrollment forms, it must be included in hard copy. For online enrollments, it must be made electronically available prior to submission of the enrollment request. For telephonic enrollments, the marketing representative must verbally inform the beneficiary where the star ratings document can be accessed. Plan sponsors and marketing representatives may not use a plan's rating in an individual category to imply a higher overall plan rating than actually exists. For example, a plan that received a 5-star rating in customer service may not advertise as rated 5 stars by our enrollees if the plan's overall rating is only 4 stars. Star ratings cannot be used in a misleading manner to influence enrollment based on inaccurate information. Marketing representatives may not use updated star ratings until CMS releases the information on Medicare Plan Finder, and old ratings cannot be used more than 21 days after a new release. By following these practices, marketing representatives ensure that beneficiaries have accurate, transparent, and up-to-date information on plan performance, allowing them to make informed choices about their Medicare coverage. Marketing representatives must never market non-healthcare-related products, such as annuities or life insurance, during any Medicare Advantage or Part D sales activity or other marketing interactions with existing enrollees, as this is considered cross-selling. They also may not market that the plan sponsor will refrain from disenrolling individuals due to failure to pay premiums. When using provider co-branding partners, marketing materials must clearly indicate that other providers are available in the network, and all sales and enrollment-related telephonic contacts must be recorded in their entirety. Representatives may not use Medicare beneficiaries to endorse a plan unless the beneficiary was enrolled in the plan when the endorsement was created. Soliciting enrollment applications for the next contract year before the annual election period begins on October 15th is prohibited, unless the beneficiary qualifies for another enrollment period, such as an initial or special enrollment period. Marketing materials that have not been submitted to CMS for review and approval cannot be used, and beneficiaries cannot be charged marketing fees. Unsolicited calls about other lines of business, such as Affordable Care Act plans, intended to generate leads for Medicare plans, are strictly prohibited. Marketing representatives must avoid any discriminatory activities, including targeting higher-income beneficiaries without making comparable efforts to reach lower-income beneficiaries. They cannot encourage enrollment based on health status, except when marketing a special needs plan for the beneficiary's specific condition. Health screenings or similar activities that create the impression of cherry-picking are prohibited. Representatives may not use unsubstantiated superlatives, such as best or highest rated, unless supported by current or prior contract year data clearly identified in the material. Comparisons between plans must be factually based, non-misleading, and fully supportable. Marketing practices that mislead or confuse beneficiaries are strictly prohibited. Representatives may not provide false information about plan benefits, provider rules, or other plan details, such as claiming that a PFFS plan is the same as original Medicare or a Medigap plan. It is not permissible to claim that Medicare, CMS, or any government agency endorses the plan. Misuse of the Medicare name, CMS logo, or government-issued materials, including the Medicare card, is prohibited unless CMS provides explicit authorization. Marketing must not advertise benefits unavailable to beneficiaries in the service area where the marketing appears unless local media reach is unavoidable. All marketing materials must clearly identify the plan sponsor offering the products, benefits, or costs. Claims of savings based on typical expenses of uninsured individuals, unpaid costs of dually eligible beneficiaries, or other unrealized costs are not allowed. The use of the term free is prohibited when describing a $0 premium, reductions in premiums, deductibles, or cost sharing, including Part B premium buydowns, low-income subsidies, or dual eligibility. Marketing representatives must not lead beneficiaries to believe that they work for Medicare, CMS, or any government agency, nor may they imply that a plan operates as a supplement to Medicare. Marketing representatives must be careful when communicating with dual-eligible beneficiaries. Unless promoting a dual-eligible special needs plan, DSNP, they may not imply that a plan is exclusively for dual-eligible individuals, or claim that the plan has a relationship with the state Medicaid agency unless a contract exists specifically for that MA plan to coordinate Medicaid services. Non-dual eligible special needs plans must not be marketed as DSNPs, and marketing efforts must not target only dual eligible individuals. By adhering to these rules, marketing representatives ensure compliance with CMS regulations, maintain beneficiary trust, and avoid practices that could mislead, discriminate, or otherwise violate federal and state laws. Open enrollment period, or MA-OEP, is a time during which individuals enrolled in a Medicare Advantage or MAPD plan can make a one-time change to another MA plan, elect Original Medicare, or change their Part D coverage. For those enrolled in an MA plan, as of January 1st, the MA-OEP covers the first 3 months of the calendar year. For individuals enrolling during their initial coverage election period, ICEP, the MA-OEP is the first 3 months after they enroll in an MA or MAPD plan. During the MA-OEP, marketing representatives are prohibited from sending unsolicited materials that advertise the ability or opportunity to make an additional enrollment change or that reference the OEP. Representatives may not engage in or promote activities that target the OEP as an opportunity for further sales, nor may they call or otherwise contact former enrollees who selected a new plan during the annual enrollment period. Targeting beneficiaries in the OEP through purchased mailing lists or other identification methods is also strictly prohibited. However, marketing representatives may focus on other enrollment opportunities during the OEP. They may market to individuals turning 65 who have not yet made an enrollment decision, promote 5-star plans regarding their continuous enrollment special enrollment period, and market-aligned dual-eligible special needs plans, DSNPs, such as FIDESNPs or HIDESNPs, to full-benefit dual-eligible beneficiaries who have a once-per-month SEP to enroll in an aligned DSNP. During the OEP, representatives may also send marketing materials at the beneficiary's proactive request, conduct one-on-one meetings with a sales agent when requested, and provide information about the OEP through the plan's call center. MA organizations may include information about the OEP on their websites. Marketing representatives should be aware that soliciting referrals from beneficiaries is subject to fraud and abuse laws, such as the Anti-Kickback Statute and the Beneficiary Inducement Statute. While there are nominal value exceptions under these laws, inducements, including gifts, for referrals should be carefully reviewed in accordance with the plan's policies. As previously noted, any unsolicited contact as a result of a referral, except through email or conventional mail, is strictly prohibited. Marketing representatives must not engage in marketing activities or provide marketing materials in areas where patients receive healthcare services. This includes exam rooms, dialysis treatment areas, hospital patient rooms, pharmacy counters, and any other areas where patients interact with providers and their clinical teams or receive treatment. Representatives are also prohibited from soliciting healthcare providers or their staff to engage in marketing activities in these spaces. However, marketing activities may take place in common areas of healthcare settings, such as cafeterias, community or recreational rooms, waiting areas, common entryways, vestibules, or conference rooms. In retail pharmacy locations, marketing may occur in areas away from the pharmacy counter. Marketing representatives may also provide communication materials to be distributed and displayed in these healthcare settings, as long as they comply with these location restrictions. In long-term care facilities, including nursing homes, assisted living facilities, and board and care homes, marketing representatives may schedule an appointment with a beneficiary only upon the request of the beneficiary or their authorized representative. Representatives may not visit individuals in these facilities without a scheduled appointment. For MA Institutional Special Needs Plans, ISNPS, staff operating in a social worker capacity may provide information, including marketing materials concerning ISNPs, to residents. This information must not include an enrollment form, and the social worker may not accept or collect a scope of appointment or enrollment form on behalf of the plan sponsor. Marketing representatives may, however, set up in common areas of long-term care facilities and allow residents to approach them voluntarily. Plan sponsors are responsible for establishing and implementing an oversight plan to monitor the activities of agents and brokers. This oversight ensures compliance with CMS requirements, identifies any non-compliance, and reports it to CMS. Sponsors must also implement strategies to prevent prohibited marketing practices, detect non-compliant marketing tactics early, and take immediate corrective action when such activities are identified. Corrective and disciplinary actions may include withholding or withdrawing commissions, retraining marketing representatives, suspending marketing activities, terminating contracts, or applying other consequences as outlined in the agreements with the plan. These measures are designed to ensure accountability and maintain compliance with CMS marketing and communications rules. Plan sponsors must cooperate with state insurance departments and other regulatory agencies during investigations of licensed marketing representatives. This includes reporting the termination of any agent or broker when required by state law, along with the reasons for termination, and notifying CMS of any for-cause terminations. Plans are also required to report to CMS any enrollments made by unlicensed agents or brokers, and must provide information requested by CMS to support oversight of marketing activities. Plan sponsors must require third-party marketing organizations, including independent agents and brokers, to disclose any subcontracted relationships used for marketing, lead generation, and enrollment. Additionally, TPMOs are required to report monthly to the plan sponsor any staff disciplinary actions or violations of rules related to beneficiary interactions. This reporting and disclosure framework ensures that both plan sponsors and their marketing representatives operate within CMS guidelines and maintain transparency and accountability. Now for the rules and requirements regarding referral fees and agent-broker compensation in Medicare Advantage and Part D plans. They cover how compensation is defined, limits on payments, when payments can or cannot be made, and how rapid disenrollments affect compensation. The guidance applies to independent, captive, and employed agents, as well as third-party marketing organizations, TPMOs, and is intended to ensure fair, compliant, and objective plan marketing practices. In April 2024, CMS published a final rule revising certain Medicare Advantage regulations, including agent and broker compensation for 2025 enrollments. The rule initially required plan sponsors to pay compensation at the fair market value (FMV) cap for initial enrollments, including a $100 administrative fee and 50% of the FMV cap for renewal enrollments. It also broadened the definition of compensation to include administrative fees and prohibited incentives that could affect an agent or broker's ability to objectively recommend plans. On July 3, 2024, a lawsuit in the U.S. District Court for the Northern District of Texas issued a nationwide stay on implementing these provisions. Until the stay is lifted, CMS cannot enforce these changes. Plan sponsors and their subcontractors may pay referral fees for potential enrollments. The payment may not exceed $100 for referrals into MA, MAPD, or 1876 cost plans, and $25 for PDP plan referrals. These limits apply to all agents, brokers, and other entities, whether employed, captive, or independent. Compensation includes monetary and non-monetary payments related to the sale or renewal of a policy, including commissions, bonuses, gifts, prizes, or awards. Independent agents who sell for multiple plans must follow CMS guidance, whereas captive agents, plan employees, or agents marketing only to employer/union groups are generally exempt. Compensation rules apply whether payments are made directly by a plan or through an agency, FMO or TPMO. Agents may not be paid if they are untrained, untested, unlicensed, or not appointed according to state law, or in the case of rapid disenrollments. If an agent contract is terminated, future payments are subject to contract terms and CMS limits. Renewal fees require agents to remain trained, tested, licensed, and appointed. Applicable compensation amounts depend on whether the enrollment is initial or renewal. Renewal enrollments include like plan moves, e.g., PDP to PDP, MA to MAPD, while unlike plan moves involve switching plan types, e.g., MAPD to PDP. For dual plan enrollments, compensation applies independently to each plan. When dual plans are consolidated into a single plan, compensation is based on the MA or cost plan movement. Initial year compensation cannot exceed the FMV published annually by CMS, and renewal year compensation is limited to 50% of the FMV cap. Referral fees cannot exceed $25 for PDPs or $100 for other plan types. Plan sponsors may choose not to pay initial or renewal compensation depending on agreements with TPMOs. Compensation is paid on a calendar year basis, prorated for mid-year enrollments, and must be recouped if a beneficiary is not enrolled for compensated months. Plans may pay full initial year compensation for first-time Medicare enrollees or those moving from employer plans, but must recoup amounts if the enrollee disenrolls. Rapid disenrollment occurs when a beneficiary leaves a plan within the first 3 months. Compensation must be recouped unless disenrollment is due to specific reasons, including enrollment effective in October-December with a January 1st switch, gaining dual eligibility, qualifying for special needs or LIS, loss of Medicare entitlement, moving out of service area, non-payment of premium, switching to a 5-star plan, institutional moves, gaining or losing employer-union coverage, auto/facilitated/passive enrollment changes, death, or enrollment in terminated/non-renewed/CMS sanctioned plans. Rapid disenrollment rules apply both when switching plans between parent organizations and between plans within the same parent organization. For example, if Ms. Howard enrolled in Plan A with an agent's help and switched to Plan B within the first 3 months during the MA open enrollment period, Plan A must recoup all compensation paid to the agent for the initial enrollment. We've covered the marketing and communications rules that apply to Medicare Advantage and Part D plans, including state licensure and CMS training requirements for marketing representatives. You learned what counts as communications and marketing materials and the difference between educational and sales events. We reviewed prohibited activities, like unsolicited contacts, misleading information, cross-selling, and improper use of star ratings, as well as what is allowed during permitted contacts and individual appointments. We covered social media rules, maintaining beneficiary confidentiality, and the proper use of plan star ratings. You now understand the Medicare Advantage open enrollment period and what marketing is allowed during that time. We went over marketing in healthcare and long-term care settings, rules for employer group marketing, referrals, and referral fees. Finally, we discussed plan oversight and enforcement, potential penalties for non-compliance, and marketing representative compensation, including limits, initial versus renewal enrollments, and rapid disenrollment rules. By understanding these rules, you'll be able to market Medicare plans ethically, accurately, and in full compliance with CMS and state requirements.